Hello, I'm Larry Needleman. I'm the medical director at Thomas Jefferson University Hospital. Today we're going to talk about venous disease, both in its acute form of venous thrombosis and its chronic form with venous insufficiency. Before discussing the sonographic appearance of venous disease, let's discuss a bit of the risk factors for acute venous disease. These have been described more than a century ago by Virchow and talked about the three aspects of the patient population who is prone to develop deep venous thrombosis. The first group are patients who have venous stasis, typically from bed rest or immobilization. This very commonly occurs in the inpatient population and occurs following surgery. The other large group is those with hypercoagulable states, either those that are born with an imbalance of their ability to coagulate, or those that develop this as a result of particularly cancer, and there are certain cancers which are more associated with this, such as pancreatic cancer and gastric cancer, and these are described as the trousseau syndrome. There are also situations where people are prone because of therapy, and one of the more common ones is heparin-induced thrombocytopenia, which can lead to a paradoxical increase in coagulation. Finally, patients who are traumatized, either from nearby fractures or from catheter lines that are placed in the veins, can also develop deep venous thrombosis. This is more of a factor in the upper extremity, but can be seen in the lower extremity as well. So, to summarize, the risk factors for deep venous thrombosis are many, including age above 40 years old, those patients that have surgery, and particularly those with surgery for malignant disease, orthopedic patients, those patients who are at bed rest for greater than 4 days, people also with any kind of chronic medical condition such as cardiopulmonary disease, and then there's prior venous disease such as previous deep venous thrombosis, the presence of varicose veins, and obesity. Another area that's very interesting for many people is the presence of DVT following long plane trips, and this is related to the particularly long plane trips that some people now are more prone to take. Venous ultrasound is an important part of the evaluation for deep venous thrombosis because this is an extremely common disease, and pulmonary embolism is considered one of the major killers of inpatients that are preventable. And prophylaxis is getting more and more widespread, but patients are still at risk for deep venous thrombosis. And the most important aspect is that the clinical diagnosis of deep venous thrombosis is not reliable. Those patients who have symptoms often do not have deep venous thrombosis. They have other processes such as chronic venous disease or musculoskeletal or arthritic processes. On the other hand, asymptomatic deep venous thrombosis is rather common and can be lethal. And in one study, only 10% of the people who died by pulmonary embolism had pre-existing deep venous thrombosis symptoms. A review of venous anatomy is broken up into what's called the central veins, those veins that are from the thigh to the knee, the common femoral vein, and the femoral vein. The word superficial femoral vein is now not considered part of the accepted nomenclature and should not be used. And then finally the popliteal vein, which is formed by the confluence of the major calf veins. So after we deal with the central veins, we are dealing with the calf veins, and they are two different sets of veins. Those that lie between the muscles, the posterior tibial, perineal, and anterior tibial veins, and those that lie within the muscles, the so-called gastrocnemius and soleal veins that are present. Just as there's a deep system, there is a superficial system, which is draining the subcutaneous tissue, and these veins fall into several categories. The large veins of the superficial system, the great and small saphenous veins, Again, these are now the new accepted nomenclatures for these veins, as well as the other veins lying in the superficial system that are tributaries to these veins. There is also veins that run between the deep and superficial system, the so-called perforating veins. And finally, the veins that communicate between one part of the system and another. Another aspect of veins are their valves. These are quite important to control the direction of blood flow. They are more numerous as you get further distal in the leg, so the calf veins have many, many more valves than do the veins in the thigh or pelvis. A long axis view of the vein shows that the vein is slightly distended in the region of the valve. That's a sinus. Here are the fine valves that can be seen here, and you can see that there are echoes that exist behind the valves. This was not deep venous thrombosis. This was just blood which is collected behind the valves, and these were easily removed with augmentation distally. Deep venous thrombosis can be symptomatic or asymptomatic. The location of the thrombi varies in those two groups. In the symptomatic DVT patients, the thrombi tend to be larger and involve the larger veins. As we can see from this study from the 1980s, using venography, 84% of the thrombi that were present in patients who were in the proximal veins, while only 16% of the thrombi were present in the calf veins. This is in distinction to their group of patients with asymptomatic deep venous thrombosis. In screening surveillance venograms, approximately 50% of the thrombi were in the proximal veins and 50% of the thrombi were in the calf veins. When we look at the natural history of venous thrombosis, we recognize that thrombi tend to begin in the small veins of the calf. As this process develops, the thrombus doesn't necessarily grow continuously from the calf into the more proximal veins, but that the thrombi now is seated in other veins which are present. So independent thrombi are present. That means when you scan patients, you may find thrombi in one vein, see a normal segment, and then see thrombi in a second venous segment. The thrombi begins behind those vein valves, typically in the calf veins. As it gets bigger and bigger, it's going to be free-floating in the lumen of the vein, and then eventually actually fill the vein and attach completely to the wall. Even as the body is creating a thrombus and it's getting bigger, the body is acting on this and beginning to retract the vein. So there's a natural ebb and flow and growth and regression of the thrombi. As the thrombi again tends to age, it will separate from the wall, and this is why when we see the most thrombi clinically, we can see flow around the edges of the vein, and also why we can see contrast flowing around the veins on venography. As the thrombi matures, it can start to pull back and retract against the wall. Holes or lines may appear within the veins, equaling recanalization. And at several months, you may not see any evidence of the thrombus in the vein, or in about a third of patients see some scarring, or a filling defect completely filling the vein may be present in about 15% of patients. We can see a picture of this where we can see on the top the free-floating nature of the thrombus coming from behind the vein valve wall, and then to the left the vein completely fills with thrombus, and then the recanalization as the thrombus breaks down the middle. On the right we can see with the effect of retraction where part of the wall is separated and it gets closer and closer to one remaining wall. And then a third part of retraction where it actually separates from both ends of the wall, leaving a narrow band of tissue or fibrosis in the middle, a so-called web-like change or Synechia. And we can see any or all of these in patients who have chronic venous change. Venous Technique is to typically use a linear array transducer and to scan the patients in the transverse plane. The frequency is appropriate to the size of the leg. Most patients can be scanned with a 5 MHz transducer, although a very large demonous leg may require a lower frequency. Typically, vein compression is performed every centimeter or every 1 to 2 centimeters down the leg. Sector transducers can also be used and particularly helpful in some patients when compression is difficult, to give a wider compression on the patient. Transverse images are adequate to document a normal study, but long axes are very helpful, particularly when there are filling defects, to get a sense of the contour of the thrombus which is present. We look at echogenicity, but we're particularly interested in what and how the thrombus fills the vessel, the size of the overlying vein, and what's happening to the vein, whether it's distended or compressed. We typically want the patient to be in a relaxed state with the heart lying above the veins, so the patient is in the supine or reverse Trendelenburg position with the thigh gently externally rotated. For the popliteal fossa, we want the leg gently bent and not hyperextended. Any position where you can get to the popliteal fossa is acceptable, whether that's a decubitus, prone, or a foot and lap position, scanning from back to front. For the calves, some investigators very much like the patient's leg dangling or sitting in your lap and scanning from a sitting up position. Other people use a similar supine or reverse Trendelenburg position. The short axis is used for compression. The long axis, however, is the preferred methodology for spectral Doppler. And here we can see a long axis of a calf vein being studied with a spectral Doppler transducer. Now, the normal findings in Doppler are of variation which occurs with respiratory changes. This is so-called phasic variation. And when this gentle changing with respiration is absent and there is no change between the breathing, the vein signal is called continuous. Additionally, if the vein is completely occluded, there won't be flow within the vein, and an absent signal is another sign of abnormal disease. Here is a spectral Doppler of a normal femoral vein, and we can see several things. First of all, the vein velocities are changing over time. Secondly, we can see that the peak in those velocities actually are changing over time, with a difference between the peaks being affected not by cardiac effects, but rather by respiratory effects, where the peak velocities change with respiration. On the other hand, the continuous signal has no changes, either due to breathing or due to cardiac effects. And there is a differential diagnosis associated with this. There is venous obstruction, either due to intrinsic venous process such as deep venous thrombosis or extrinsic obstruction. If a patient does have scarring from the veins from prior thrombosis, the vein may have been continuous from that prior disease and never renormalized. So in the differential, we must also consider that there was a prior thrombosis with collaterals, and so history is very important when evaluating the patient with a continuous venous signal. Compression is quite simple. The artery and vein lie next to one another. When compression is placed, the vein disappears completely, and so here you see the artery and no vein. The vein compression usually is quite gentle and usually easy to accomplish. On some patients with venous hypertension, it may be difficult to completely compress easily, but if you see deviation of the artery, then the corresponding vein should be completely collapsed. There is one process by which people who record images for non-compressible and compressible sometimes leave a little bit of vein so that you can see where the vein was on the compression images. I don't feel that's a very good idea because it's difficult to separate a partially compressible vein from a completely compressible vein with this. So I like pictures where I can't see the vein completely, where I understand that the vein has disappeared because it's completely coapted. Now, veins that have residual material within them or do not compress completely also have a differential diagnosis. First, let's go to the pictures. On the left, we can see that there is a vein with a echogenic heterogeneous material within it. And when we look with compression, what we can see is the vein has gotten smaller and a little bit closer to the surface, and that there is a difference in shape, whereas the acute thrombus was rounder on the left. On the right, we can see it's taken on a bit more oblong shape, meaning that it's deforming and changing shape. This deformable, non-compressible vein is typical of acute deep venous thrombosis, but the vein may not go away for other reasons besides that. There could be scarring in the vein and material in the vein that is not acute, and the vein would not go away, or that the technical factors where the vein was not compressed adequately. So how do we differentiate from acute venous thrombosis from scarring? Well, acute venous thrombosis tends to have veins, thrombi, that are somewhat soft and changeable or deformable with compression. As a rule, the veins are larger because the veins tend to engorge, the thrombus tends to engorge the vein. When we look at the outlines of the thrombus, it tends to be smooth. And in some patients, we can actually see the thrombi moving in real time. This free-floating thrombus is always acute venous thrombosis. Again, the deformability of the vein and the non-compressibility is our marker for acute deep venous thrombosis. Long-axis views can be helpful in that we can see the distension of the vein. Here at the caudal end of the picture, the vein is small, and you can see that it distends quite dramatically in the middle and at the cephalad end, and there is thrombus all the way through above this cephalad component. In addition, I want to point out the echogenicity of the thrombus. It is said that fresh thrombus tends to be anechoic and older thrombus tends to be echogenic, and while that's true as a usual rule, most thrombi which are acute with modern equipment tend to be somewhat echogenic and be somewhat heterogeneous. And so echogenicity per se is not a criteria for separating acute deep venous thrombosis from scarring. Color Doppler can be used to look at a filling defect in the vein. We can see the echogenic thrombus here, and we can see some of the filling defects in the vein here with the corresponding artery being colored in blue. However, this is not as helpful a sign as compression, and compression ultrasound remains the most evaluated sign for differentiating a normal vein from an acute thrombosis. I tend to use the word chronic venous change or scarring rather than chronic venous thrombosis because after about 2 weeks, the material in the vein is no longer a thrombus, it has re-endothelialized, and so another term I think is preferable. As we look at what chronic changes in the vein look like, we are looking at the evolution of the material in the vein from retraction and recanalization, and so the material in the vein tends to no longer be soft, it tends to be stiff, it heals irregularly and so has an irregular surface. You can get those web-like changes as we described before. Again, if recanalization is nearly complete, you may just have a rim of wall thickening. And in terms of size, the vein tends to be normal-sized or small. In this long-axis view, we can appreciate the fact that the material inside the vein is heterogeneous and perhaps more echogenic than usual. We can see some bright echogenic reflectors inside this scarring as well. But the more striking abnormality is the marked irregular shape of this material inside the vein, indicating that this is a result of the retraction of the material. You can see that the vein itself is normal sized. Here, on the other hand, is an area of Synechia here at the cephalic end of the vein with this linear change which is present. And I also want to draw your attention to the vein wall. Long axis views can be quite helpful in that we can see that the wall is pulled in here, which would not be a sign of acute disease. This is, again, a sign of scarring, this pulling in effect. Here at the caudal aspect of this material, we see this material on top of the Synechia or a thickened Synechia. And the two can be differentiated by compressing in real time. If that material is soft and lying on top of the thin white line, then it's likely acute on chronic disease. If, on the other hand, this material is stiff and unchanging. It's just a thick web-like change. In short axis, we can often see many of the same findings in scarring. Again, some of these linear echogenic lines that are present inside the vein represent the Synechia, or fine web-like changes that are present, but there is residual material in the vein which has a somewhat triangular shape in this case. And again, what's striking is the irregularity and undulating nature of it and the angulation. Again, this is not the smooth, rounded structures that we expect to see in acute deep venous thrombosis, but rather somewhat angulated, triangular appearance from scarring and retraction. The artery is above here. We can see the aliasing, and the striking finding here is in the vein, which has a blue lumen, but you can see that the wall of the vein is thickened on both sides in a very uniform pattern around both the anterior and posterior aspect of the vein, indicating a circumferential wall thickening, again the result of prior recanalization. Recanalization in process can also be done, can be seen and also seen in part of retraction here. We can see the residual lumen forming around the vein as well as around the edge of the vein. Collateral veins can be seen when there's obstruction. We typically see them in more chronic conditions, but can be seen in acute venous obstruction. Here we can see a patient with chronic changes. The vein is chronically occluded. It's the small hypoechoic structure running through the image. And we can see that there are venous structures lying on the wall of the vein here, as well as venous structures that are bypassing this obstruction above the vein here. When we look at our lower extremity protocol, we want to make sure that we have a complete evaluation. And this includes evaluation of the common femoral vein, including the saphenofemoral junction, the entire length of the femoral vein, the central portion of the deep femoral vein, and the entire portion of the popliteal vein. At the very least, evaluation of the calf should include any areas that are symptomatic, and many centers include the calf veins as well. The calf veins are quite numerous, and protocols for calf veins can be quite simple, from one view of the posterior tibial and perineal vein to multiple views separately evaluating the posterior tibial, perineal, soleal, and gastrocnemius veins in both their medial and lateral compartments. Here are an image of the calf veins, the major calf veins, the posterior tibial in the near field and the perineals in the far field, as noted by their normal structure and normal location and the corresponding arteries traveling within them. The calf veins are becoming more and more important and getting to be part of people's understanding of deep venous thrombosis. As our imaging gets better, our ability to see these veins become easier. And of course, we can see that this veins are the earliest part of the clots that are present. We know that from natural history, but we also recognize that they're a marker for more central disease appearing. In about 20% of patients who have calf vein thrombosis, more central deep venous thrombosis will appear. And so this is one of the reasons why people are very interested in intervening with people with calf vein thrombosis before it gets to proximal deep venous thrombosis. Proximal DVT is much more likely to produce symptomatic pulmonary embolism, and so it's a more severe disease than isolated calf vein thrombosis. Additionally, some people are very interested in calf DVT because of an increased risk of chronic venous insufficiency and the risk for future deep venous thrombosis. And so the American College of Chest Physicians recommend treatment of symptomatic calf vein thrombosis. If patients are not treated for symptomatic calf vein thrombosis and it's identified, a follow-up ultrasound must be confirmed to make sure that this patient is not one of the 20% of patients who will have disease which propagates. As I said before, about 17% of patients who are symptomatic will have isolated calf vein thrombosis. If you consider that about 20 to 25% of patients who are sent to the lab have deep venous thrombosis, about 4% of the patients who are symptomatic who come to the lab will have isolated calf vein thrombus. The American College of Chest Physicians, again, recommends treatment, and recognizing this, the guidelines for the various agencies have varied. And so the ACR and the AIUM guidelines, which are current, state that the patient presentation, clinical indication, or clinical management may require protocol adjustments such as detailed evaluation of the superficial system or evaluation of the deep calf veins or a bilateral study. The ICVA, which is the Intersocietal Commission for the Accreditation of Vascular Labs, in their recent guidelines includes evaluation of the posterior tibial and perineal veins as part of their guidelines for accreditation. Here we can see that there is a calf vein thrombus. There's the calf vein on the left, and with compression, the vein does not go away, indicating that there is a filling defect and therefore acute venous thrombosis. The problem of venous ultrasound and calf vein thrombosis is not one of specificity. That is to say, if you find a filling defect in the calf vein, it is almost certainly acute venous thrombosis or scarring. The issue with calf vein thrombosis is sensitivity, and depending on the studies performed, sensitivity may be as low as 50% up to 85%, depending on the patient's clinical indication and their underlying conditions. Now, there's an imaging protocol, and then there is a DVT protocol, and the current ICAVL recommendations for protocol is that every patient get common femoral vein scanning bilaterally, and the popliteal vein is studied in patients. This is to look for respiratory variation, and other compression maneuvers such as distal compression can also be performed. Here we can see that the waveform is changing over time slightly, and then when we compress on the calf distally, we can see a strong augmentation from this, and this augmentation is used by some people as a sign that there's not obstruction between the point of compression and the point of insination. A few other things about the spectral Doppler. If the Doppler waveform reverses in the proximal veins, that's not typically abnormal, but if that reversal continues all the way down the leg, and here in the calf veins there's still a bit of reversal, you have to be concerned that the spectral Doppler is overly pulsatile, which may indicate right heart disease, right heart failure, or tricuspid regurgitation. Clear-cut indications for lower extremity ultrasound are in patients with a symptomatic leg where DVT is expected. We also scan patients who are high risk in the hospital setting, although this is controversial for some patients. We do not typically recommend a lower extremity venous ultrasound to exclude pulmonary embolism, since the absence of a DVT does not exclude the disease. However, it is used in some clinical pathways if the patients have symptomatic legs and chest symptoms. The presence of a DVT is effectively a good surrogate for an imaging study of the chest, which indicates pulmonary embolism. For patients with known DVT or pulmonary embolism, occasionally we will study patients, but there needs to be a reason for this studying, as it must change clinical management. Clot in the leg, even adequately treated clot in the leg, may grow, and so just the presence of enlargement of the clot is not important in terms of treatment failure. Treatment failure is defined by other processes, such as inability to maintain adequate anticoagulation, which is blood tests, or thromboembolic disease, which occurs despite treatment. Indications for lower extremity venous ultrasound vary depending on the patient's clinical presentation and management pathways, but clearly patients with a symptomatic leg or calf whom venous thrombosis is suspected should get a lower extremity venous ultrasound. In some hospitals, high-risk patients are also screened for venous thrombosis, and this has been found with some groups such as spinal cord patients and neurosurgery patients. It is not usually indicated to exclude pulmonary embolism, but a few words about this. First of all, in a patient with a symptomatic leg and chest symptoms, it may be prudent or quicker to do a venous ultrasound study, and if DVT is found, the patient should be treated and the presumption made that the chest symptoms are related to pulmonary embolism in the presence of known DVT. On the other hand, if the ultrasound studies are normal in a patient with suspected deep venous thrombosis, further evaluation is clearly warranted, as many patients with pulmonary embolism will have normal leg ultrasounds or normal venograms. As a rule, in patients with known deep venous thrombosis or known pulmonary embolism, lower extremity venous ultrasound is not generally indicated, but if there are reasons why the study can change patient management, it could be considered. When looking at venous ultrasound, we have to recognize that the study is incredibly accurate for the central veins, sensitivities and specificities in excess of 95%. But there are some pitfalls that we need to recognize. There are certain veins that are more difficult to compress than others. Typically, the femoral vein in the region of Hunter's Canal can be somewhat difficult to compress. And some tricks are to compress from the front and the back using your hand on one side and the transducer on the other. You may have to press a little bit harder at vein junctions, such as the saphenofemoral junction, sometimes using a curved array transducer or even a sector transducer to get more exacting compression can be helpful. We need to also recognize that duplicated veins are quite common, the femoral vein being duplicated, and so we need to recognize that. Now, when veins are duplicated, they're not usually duplicated along their entire length, but we do need to appreciate the fact that there are veins that can be seen along part of the course, and if there are prior studies that indicate a duplicated vein and that is not seen, you have to be worried that the reason the duplicated vein is not seen on follow-up is that there's a thrombus within it. And the calf veins are just multiple numbers, and it can be quite daunting to visualize so many veins. From the interpretive point of view, some thrombi can be difficult to differentiate from acute from chronic. This really represents the vast minority of cases, as I think about 95% of venous studies that are positive can be distinguished from acute versus chronic. One issue, though, is recurrent DVT. Recurrent DVT is acute deep venous thrombosis on top of chronic change, and this can be a quite difficult study to diagnose. There are some clues, however. One is that an old study is available and there is a new thrombus in a location that was free of thrombus previously. The other may be that there was a small vein or small residual scarring previously, and now this has gotten larger. In fact, some people measure the size of the residual vein, and differences of 2 millimeters have been described as being significant. This may be quite difficult to match up an old and a new study, and that may be not a reasonable approach for most laboratories. Some other questions. Since we know that patients can have a dynamic process, that is to say, have thrombi that evolves and becomes into the more proximal veins, can we rule out disease with just one study? And we need to be aware of several factors. If calf vein thrombosis can be identified but not treated, we need to rule out propagation of this thrombus. And this can be done by doing a follow-up every 5 to 7 days for 2 weeks. And if there's no central thrombus, then the patient needs no further follow-up. There are lots of people who do not study the calf, however, and there's controversy in how to work these patients up. a lot of work is being done on this, including ultrasound combined with other things such as D-dimer test, which is a blood test, and pretest probabilities. One thing I can say from a variety of the literature out there, of the 3 studies, a negative ultrasound, even one that does not include the calf, a negative sensitive D-dimer, and a low pretest probability, if any 2 of these 3 are negative or are not indicative of DVT, the workup can stop. Another approach to using ultrasound is to look at limited studies above the calf and doing 2 studies 5 to 7 days apart. And it's been shown in several studies, of which this study from the Annals of Internal Medicine is the most well regarded, that 2 studies 5 to 7 days apart adequately exclude deep venous thrombosis. The risk of DVT in a group that were normal on 2 separate occasions was 0.6%, which is way safer than a single negative venogram. And so this is a safe approach. So we have 2 different approaches, 2 studies 5 to 7 days apart, and using combinations of D-dimer, negative ultrasounds, and low pretest probability. Well, what if you just do one limited test and don't look any further? Assuming 20% of patients have DVT, and 20% of those have isolated calf clot, 4% have calf clot that would be missed by this technique. And if we assume 20% of those patients, the calf clot will propagate, about less than 1% will develop proximal DVT, and of those 1%, only 0.4% will develop PE. So the overlying risk of patients who have no calf vein studies are already unlikely to have disease. Another question that comes up frequently is, does the study need to be performed on both legs, or is one leg adequate? First, let me state that spectral Doppler of the common femoral vein should always be performed on both sides, whether the patients are symptomatic in one leg or both legs. This is because symmetry is important to diagnose iliac obstruction, and since we don't usually compress the iliac veins, the Doppler becomes an important test to the presence of more proximal obstruction, either in the iliac or the inferior vena cava level. As for looking at both legs, let me just also say that if you think spectral Doppler is an important criteria and bilaterally symmetrical Doppler is an important criteria for you, then this needs to be performed on both legs, even if the symptoms are in one leg. For the most part, however, the question of unilateral versus bilateral comes down to what is the risk of an asymptomatic leg harboring DVT. And this has been looked at by several studies. Here are 2 from both the vascular surgery and the radiology literature. And I bring your attention to all these patients in the first rows have unilateral symptoms. And if we go to the far end here, we can see that the risk of the patient having clot, not in the symptomatic leg, but on the asymptomatic leg, is only 1%. And so that's quite low. From my point of view, this does not justify routine evaluation of the asymptomatic leg. However, if we look at this data a bit more carefully, we can see that there are some subgroups of patients where the asymptomatic DVT is a bit higher. That is 4% in the group with malignancy, 5% in the group with joint surgery, and 9% in the patients with hypercoagulable states. And so there are subgroups of patients who deserve bilateral studies even when one leg is symptomatic. And in patients with cancer, patients with joint surgery, and patients with hypercoagulable states, we do bilateral studies even in patients who have symptoms on one side. We also study our trauma patients with both legs because we feel that this is a particularly high-risk group. The next interesting question is, does venous ultrasound need to be available 24 hours a day, 7 days a week? And of course, if you have ultrasound sonographers or vascular technologists or in-house all the time, venous ultrasound should be performed when it's indicated, but many institutions don't have this. And so what can we do? Well, at Jefferson, we don't scan patients 24 hours a day, 7 days a week. There are patients who are seen off hours who wait until the next day. And either they wait or they get treated with low molecular weight heparin and wait for their imaging the following morning. The patients who get scanned immediately are those patients with a contraindication to anticoagulation, which need the study soon after the test is ordered. And so the contraindications have been worked out by a subgroup of people, both ER physicians, vascular medicine, vascular surgery, and radiology physicians. And the contraindications for anticoagulation are as follows: heme-positive stools, ulcers less than 6 weeks, low hemoglobin, central nervous system surgery, closed head injury, and strokes. Patients other than this group generally wait until the morning for their studies. Now, is this a safe procedure to give low molecular weight heparin and wait for confirmation? Well, this is from the emergency medicine literature, and these were patients who were not had imaging after 4 p.m. or on weekends, and they studied 128 patients, of which some of them had pulmonary embolism and some of them had acute venous thrombosis. And so that was 44 of their patients, of the 128 patients. And neither in the group with DVT or PE or the group without DVT or PE were there any adverse effects from giving anticoagulation with low molecular weight heparin. So it's felt to be a safer approach to defer imaging in patients with suspected deep venous thrombosis. I'd like to go and just talk a little bit now about chronic venous disease, of which the most common condition is varicose veins. This has become increasingly of greater interest because of the treatment options for varicose veins that are becoming more widespread, namely endovascular laser or radiofrequency ablation of these varicose veins. So varicose veins are veins that are dilated and start to lose their function. As we can see in this image, we can see that in this varicose vein, the valves are separated and therefore reflux freely, where here in the perforating vein or the deep veins, the valves are competent. And so this is primary varicose veins. So valves are quite important because if you were to have a valveless venous system, when you stood up, all the blood would become one column from the heart all the way to the leg, and the pressure on the veins and from the hydrostatic column would cause the leg to swell, and all the blood would pool in your feet, and you'd pass out. So the valves break up the column of blood, and so that the pressure of the hydrostatic column only exists between one valve and the next. And there are many, many more valves in the calf, so this pressure is broken up into many, many different tiny portions of blood columns. The valves also control the direction of blood flow from the deep system to the heart and from the superficial system into the deep system, so that blood is pushed from the superficial into the deep system and out the deep system, pushed and propagated by the calf muscle pump back towards the heart. Now we need to remember that valves, when left to their own devices, will stay normally open. So when we're looking for reflux, we need to prove that the valve actually closes. We need to create enough back pressure so that the valve would normally close, and then when we see abnormal retrograde flow through the vein, that indicates reflux. So we cannot just look at the leg in supine position and determine whether or not reflux is present. Most varicosities that we see are related to our human nature of standing up and the valves and the veins becoming distended without venous thrombosis. There is a class of patients who have valvular disease from prior DVT, the so-called post-phlebitic patients. In this case of acute deep venous thrombosis, we can see the echogenic thrombi filling the vein, but you can see here the sinus and the valve cusp are subsumed by the DVT. And even after this material resolves, the veins are diseased and won't function normally. So in evaluating patients with venous incompetence, we not only want to look for reflux, but we want to look for the presence of residual thickening or prior deep venous thrombosis or scarring in the veins as a clue to the etiology of the venous insufficiency. In evaluating the patients for chronic venous disease, we concentrate in particular on the saphenous veins, both the great saphenous vein and the small saphenous vein, but also want to evaluate any sites of symptomatic varicosities, which may be in the tributaries of the veins, such as the posterior medial branch or the anterolateral branch or other branches of the saphenous vein. Here in this image, we can see the saphenofemoral junction and the saphenous vein as it's coming down. The saphenous vein may be varicose itself, or the varicosities may lie within the tributaries of the vein. When we look at the small saphenous vein, we want to recognize that this is the vein that runs through the calf and typically terminates in the popliteal vein, but there are lots of normal variants that are present, including, as we can see here in the upper right, a thigh extension vein, which extends up and often leads to the vein of Giacomini with an intact saphenopopliteal junction, or down here, a thigh extension vein with an absent saphenopopliteal junction, or variants of that as seen here on the bottom left of just a small saphenopopliteal junction. So how do we evaluate patients for reflux? Well, most patients should be studied in the erect position. 15% reverse Trendelenburg is also reported, but the standard is to have the patient standing with the leg relaxed and not bearing weight. We should never evaluate patients for reflux in the supine position, as it can be false positive reflux. And the standard is distal compression with rapid release, typically done by hand. Some people also Valsalva, and this Valsalva maneuver is acceptable at the saphenofemoral junction, but not distal to that. What constitutes an abnormal amount of reflux? Most people would say a reversal of flow for greater than half of a second is evidence of reflux. And protocols can be quite variable, but I think that you want to evaluate both the great saphenous and the small saphenous. Look for enlarged tributary veins, particularly if they are varicose when you stand the patient up, to look for obvious perforators, including perforators which are incompetent, and evaluate for the presence of reflux. Similarly, or additionally, if you're going to ablate the patient, you want to evaluate the venous size and the depth to see if it's appropriate for ablation. This is an examination which is normal. You can see the normal flow within the vein, and then with Valsalva, there is a tiny blip of reverse component, and then no reverse flow at all, and then with release of Valsalva, the flow continues. Let's speak about this small reverse blip. The veins take some time to close, so as the pressure builds beyond the valve, the veins will leak a little bit, and then flow should stop. And a small amount of flow in the reverse direction is not indicative of reflux, and that is why we require more than a half a second of reflux, and values less than that are not significant. We've demonstrated the findings of acute venous disease, scarring, and venous insufficiency. Thank you for your attention.